It is my great pleasure to welcome you to the 2025 CareOregon Pregnancy and Substance Use Disorder Learning Series. Before we get started today, I want to start off with some gratitude for the folks who made this possible. Our Learning Series Planning Committee met regularly to select the topics for all 3 days, as well as the experts who are presenting on them. We wanted to provide a really comprehensive curriculum that would benefit veterans in the field, as well as those who are new to the realms of substance use disorder or perinatal care. This group of experts cares deeply for this highly stigmatized group of people, and they are dedicated to improving the experiences this population has when seeking services. The golden thread throughout each of the presentations and throughout each of the days is to eliminate bias and stigma and to provide excellent evidence-based care to those who often don't seek or return to services due to judgment and fear of consequences. It's been such a joy to work with this group on the project, and I invite everyone to give them a round of applause. This series takes place on 3 separate events spanning from today until April 4th. Each day has new and exciting content. You do not have to attend all 3 to receive CME credits, but we hope that you do so that you can build this community and participate in this community. Each day has a unique theme. Today we are creating a shared language and understanding of substance use disorder and best practices on how to provide stellar care and navigate folks to appropriate resources. Day 2 is all plenary sessions, and there will be no breakouts. We will begin the day with a midwives and doula panel, followed by sessions about cultural consideration of the Black and African, Latina, American Indian, Alaska Native communities. We will end the series in April with a day that is around care coordination throughout the SUD care continuum. There will be a Peers with Lived Experience panel, as well as representatives from the 4 current Project Nurture programs in the metro region, and we really hope that you can join us for all 3 days. If you'd like to sign up, there's also a QR code on your agenda where you can. Here's today's agenda. We will spend most of our time here in the ballroom, and from 12:45 to 1:45, we will have the opportunity to choose our own adventures and attend one of 3 breakout sessions. Please don't be entirely too sad if you cannot clone yourself and attend all 3. My colleague Ian in the back is recording these sessions for us, and they will be made available at a later date. And after the breakout sessions, we'll rejoin here at 2 p.m. For our final session until 3. Okay, so each day has 4 sessions, and so there are 4 CEUs available, or Maintenance of Certification Part 2 credits for physicians who need those credits for certification. There is an evaluation link that will be sent out at the end of the day, and it is on your agendas as well as the very last slide of the day. Now, I'd like to formally open the Pregnancy and SUD Learning Series, and before I turn it to my colleagues, I'd like to tell you how we got here and what to expect. The Health Share of Oregon Substance Use Disorder Task Force meets monthly with the goal to ensure evidence-based, equitable, recovery-oriented SUD systems of care across our network. We aim to do this by optimizing integrated care models like Project Nurture for our members with SUD, and we want to create opportunities like this one to share evidence-based practices and resources. Health Share of Oregon and CareOregon facilitate the monthly SUD task force, and this task force identified a need for education and care coordination specific to those who are experiencing pregnancy and postpartum while experiencing a substance use disorder. Pregnancy is life-changing. I think that's an understatement. And this period of time can be especially challenging for those who use substances, for a host of reasons. Many experience barriers to care, so many don't seek services until it's time to deliver. Past experiences of trauma and stigma can ignite shame, and this shame is a powerful force that keeps pregnant people from seeking the care they need. People of color frequently do not have access to providers and other supportive people who share their lived experience, their identities, and their culture. And fear and uncertainty around legal consequences and the possibility of children being removed from the home also keep pregnant people from seeking care. We hope that this series will equip you with knowledge and tools and will help you identify and address stigma and bias. And we want you to help those in your care feel empowered, confident, and listened to. Here's a list of the best practices that the task force identified through conversations with providers, with our community, and through extensive literature review. We hope that you will gain a solid foundation of knowledge and add the resources and practices shared here to your toolbox. Here are even more best practices. And in the spirit of navigating individuals to the most appropriate levels of care and improving outcomes with education and empowerment, I'd like to move us into our first of today's sessions. Our first session is going to provide everyone here with a shared language and understanding of what a substance use disorder is, what treatments and supports exist. And without further ado, I am honored to introduce my dear friend and colleague, Aly Gray.
Good morning. Oh my gosh, I told them to laugh really loud at my jokes. That wasn't even one yet. Good morning, everybody. My name's Aly Gray. I use she, her pronouns. I work at CareOregon as an innovation specialist. Before then, I was working at Columbia Pacific, still within the CareOregon family, as an SUD program specialist. Is anyone here outside of Portland? No? Great, cool, rock on. Okay, cool. So I was over at Columbia Pacific as an SUD program specialist. Before then, Cascadia. Any Cascadia rep? Yeah, all right, hey. Okay, so we're gonna be going pretty quickly through my slides. As Kayla already brought up, you will have access to these slides, and my slides have a lot of hyperlinks. So later, if you're like, oh my gosh, I remember something really awesome, you'll be able to navigate that. So even though we will go kind of quickly, I kind of forgot that I am a professional certified yapper, so that might really influence the pace and the flow. So here are our learning objectives, and my goal for this is to really just be a little appetizers. I want to kind of just get our brain percolating for today and our next day 2 on our learning series, day 3. So if you have questions throughout this, we definitely will have some time to talk about them after, as well as there are going to be presentations in all 3 days that will continue these conversations. So you might hear things more than once, but sometimes we need to hear things more than once. These things are really relevant. So we're defining the SUD and understanding the complexity of substance use. We're also going to be describing the purpose of universal screening and person-first assessments. We're going to be recognizing the importance of matching individuals to the appropriate person-first treatment. And then we're going to be talking about harm reduction. I am so excited. Can't wait. Okay, this is a super helpful slide just so that we're all on the same page. For some folks, we're like, I already know this. Great, you're going to help me. SUD, just so we're all on the same page, substance use disorder. Then we have OUD and AUD for opioid use disorder, alcohol use disorder. And then we get into some acronyms that are specific around medication. So MOUD, you'll see for medications for opioid use disorder. MAUD might be one that we haven't seen too often for medications for alcohol use disorder. And then sometimes, in order for us to not just have alphabet soup of putting both of those together, you might see MAT for medications for addiction treatment, all right? We really want to hammer home that when we think about substance use disorders, we're talking about a treatable chronic medical disease. We're thinking of this in the medical framework. By doing this, we can kind of help have some really great conversations. We can kind of just start using terms without big stigma, without big emotion. We already have a bunch of big emotion having the conversation to begin with. So if we can just use some medical terminology, we can kind of break that down a little bit. So we have this ASAM quote here around it being a treatable chronic medical disease, but it also includes that prevention efforts and treatment are generally as successful as those for other chronic diseases, and people need to know this. We also know that substance use is a spectrum, and we're going to talk about that in our next slide too, that sometimes we have this thought that if someone is using substances, they automatically meet criteria for a substance use disorder, but we also know that it's way more complex than that. We also know that not all folks, this is kind of what I'm saying here, is that they don't all meet criteria for that DSM-5 criteria. And then regardless of history or initial prognosis, we know that clients deserve screenings and conversations and assessment and access to support and treatment, that it doesn't really matter if you already knew them from before, doesn't really matter where they have been in different stages of their life, where they're deserving of that conversation, that same screening that they give to everybody else. And that's what we're going to be talking about. So this is a gorgeous infographic. I love a rainbow. If I can put a rainbow in a slide, sign me up. So we have the substance use spectrum here, and what's great is just kind of recognizing that there's more than just one reason why folks get to the point of meeting criteria for a substance use disorder. So we have folks that are non-users, we have some for beneficial use. Many of us have used Advil, many of us use caffeine. We also have our lower risk use, our higher risk use, and then we get to our level of substance use disorder. So recognizing that substance use is a spectrum can really help break down some of that stigma. When somebody discloses to you, hey, I'm using a certain substance, and not just going straight to this assumption that we can very commonly mistakenly make of, oh, you are all the way at that dark orange. I feel like the only thing that I didn't really hammer in is that we really want to stay curious. My partner and I often say, curious, not furious. This is helpful when your family doesn't do the dishes, but it's also helpful when we are coming in and somebody says something to you like, hey, I'm back to use. Okay, we're gonna come in with that curious and not furious, right? All right, let's talk about screening and assessment. And let me tell you, the meat and potatoes, I'm gonna tell you the answers. There's no quiz. That stresses me out, and I'm not even the one that has to answer the questions. What we are basically wanting to do is that for every single person, we want to conduct a careful and empathetic and non-judgmental interview with every single person. We're asking the same questions that we would ask everybody. So that way, we aren't just making assumptions around how they're going to answer. Even if these questions might feel like they're embarrassing to ask, or we might think we already know the answer, that's okay. By giving people the choice to answer how they want to, we can also have both person-first treatment and also be trauma-informed and be overall awesome. Those are the most important things. Okay, so when we're talking about screening, especially for prenatal drug use, here are some of the things that we are talking about. So, like I said already 10 times, we're doing universal screenings at first prenatal visits because we know that it improves outcomes overall. We also can use some validated tools. We're going to talk about one of them that's pretty easy. We want to avoid that selective screening, like we've already talked about. That trauma-informed approach we'll talk about really soon. And then following up. So we're not just being like, oh my gosh, so glad I did the screening, good job me. That really defeats the purpose, right? Let's talk about a pretty basic, pretty easy screening tool, something that you could pretty much easily do in any setting, in any capacity. We're asking these 4 questions, the 4 Ps, pretty easy to remember. This generic tool without the like fancy parts that you could add later, it's like getting like just the normal subscription, but you might have some ads, you know? The generic one is not copyrighted and it's free to use. And you can ask these 4 questions. Parents, did any of your parents have any challenges with alcohol or other drug use? We know that separating alcohol and drug use is another whole thing of like, yes, but these are the actual questions that they are recommending. Then we also have partner. Does your partner have any challenges? In the past, have you had any difficulties? And then in the present, in the past month. What we really like about this is that this is really just conversation starters. These are things that you can ask everybody without making assumptions about really anything. We're just coming in with a curious mind. Now you might be like, oh my gosh, those 4 questions do not work in my setting. That's totally groovy. You do you. This super helpful clinical resource can help you decide which screenings are going to work best for you and your individual client needs. So when you all get these slides, you'll be able to click on this link and you'll be able, these are some screenshots of what the website looks like. And you can kind of figure out, okay, what's going to work with the least amount of questions or is free to use, all that good stuff. We also really want to make sure that screening is not the last stop on this train that we call treatment. You know, just having the questions answered is really going to open up sometimes a big can of worms, and then we're like, all right, see you in 3 months. What we want to do instead is recognizing that we are going to be having the screening as well as these conversations, doing some data collection. We're doing a bunch of things, and we're also thanking them for asking or answering these questions. We're doing this work and not just being like, okay, well, that screening was back in the intake, and I haven't really looked at it since then because they already did it with an intake person, and I'm not the intake person. Yeah, I'm saying that because I have been a person that used to do that, and now I'm trying to be better, you know? I get it. A lot of times people are like, okay, but the screening is cool, but what about the ASAM? People really want to know of like, do I have to do an ASAM for every single person? What's super helpful to know is that, you know, not everyone in every single setting, ASAM is what is the flow and what we're going to be doing. So if you are a BH provider that is holding that certificate of approval, yes. In other situations, other screening tools, other assessments, other things might be a better fit for you. So we're just kind of recognizing, yes, ASAM, and also knowing that each situation is going to be different. So just kind of recognizing, making sure that you and your agency are on the same page of whether or not an ASAM is your best bet. All right, we also want to think about, once you've done the screening and once you've done the assessment, what about treatment? So we need to also be considering that our treatment options are going to be unique to the actual client themselves. Too often, we kind of just say, oh, well, you screened really high on this thing, so now you are now in this big group of people that all get the same thing. We know that that is very common. We kind of want to break that up a bit. So what's the most effective and least restrictive? What is the patient's capacity? A lot of times people are just not coming into treatment, and instead of being curious, we're just like, well, they're just not coming. Or maybe they've got some childcare needs, maybe some pet needs, some employment needs. We're also thinking about culturally specific needs and post-treatment considerations. There's so many times where I'm like, why aren't you coming into treatment? And that's because they might be at risk of losing their housing if they were to do something like that. Or there's a bunch of different reasons why people might not go into treatment. So we want to kind of keep that door open. We're staying curious. Here are some other things that I really want to cover in our first-person treatment conversation. This is a Kayla joke so many times. Kayla will be like, treatment is not just Sandra Bullock in 28 days. She is so funny. I stole that from her. TM. And it's so true. We have so many different treatment options, as well as treatment starts just from having these open conversations. So this is a gorgeous, another infographic. This is ASAM specifically is kind of showing you that, like, yes, it isn't just Sandra Bullock in 28 days. And a lot of times what will happen is we can get somebody to start treatment. We've had this conversation. They're excited. They're like, okay, let's do it. And then you're like, oh, what do we do now? Okay, why don't we start by having this person-centered mindset? We're building trust and rapport. We want to tailor our interventions to our individual. These are things that we've talked about already. We're emphasizing strengths and resilience. What are some of the things that they've already got going on in their supports? Awesome, let's roll with it. We've talked about reducing stigma. We're wanting to promote that holistic integrated care, encouraging self-determination, and then fostering that recovery-oriented community. Here are the first two. I wanted to go through all 8, but I really feel like a lot of you are like, I know that I am gonna go home and with my super fun reading, I'm gonna do this at home. It's gonna be so great. I believe you. We're gonna embrace that person-first mindset. So what that means is essentially we're focusing on the individual and not their diagnosis. A lot of times, if we can just have a conversation with them that really has nothing to do with their diagnosis at all, it can really just kind of start talking, we're talking to people, right? So a lot of times I'll talk to them about my video games. Y'all might be very familiar with this very advanced gamer, very advanced game called Hello Kitty Island Adventure. Not to brag, but I'm crushing it. I'm so good at it. And I love talking to people about Hello Kitty Island Adventure because, yeah, okay, we're gonna talk during lunch. That should have been a card on our table. Dang it, I made those cards too. So we're building trust, we're building rapport to kind of get them to know, like, I'm here for you. We can talk about what you want to talk about. Let's have a fun conversation. So these are some things that you might have heard people say or something like it. And what I'd like us to do is kind of break them down and say, what can we do instead? What can we say instead? So here are some things that, I don't even like saying them out loud, but I'm going to do it for you, okay? Now that you're pregnant, you need to stop smoking. If you loved your children, you'd stop using. You'll probably lose custody of this baby too. Your baby's going to be addicted. I'm hearing some like, oof. Yeah, okay, the universal oof, okay? We know that perceived stigma and judgment is the most significant barrier to seeking treatment. People aren't even going to go to treatment if they know that they're going to experience that stigma. The fear of being negatively labeled, judged, or misunderstood prevents people from reaching out for life-saving help. If they know that people are going to be making comments like that, it's going to be really hard to even get them in, all right? So let's talk about what we can do. Okay, y'all, this might be your first time hearing about motivational interviewing. It might be your 20th, but let me tell you, it is the best way to get your family members to do the chores. It's the best way to get people to help you do the things that you want them to do. It's great. We want to ask questions. We also want to really listen, and then we want to give information and tell. So this is a screenshot that I took from the National Harm Reduction Coalition. But in my dream scenario, I'd probably flip the tell and listen. So I would be like asking questions, really listening to what they're saying, and then the tell part of giving them some information. So what I'm wondering if maybe if we switch some of these things and we gave some different questions, is it going to maybe start some real conversation? Are we going to get some more dialogue and get people curious? So what if we change it to, what do you think about your smoking now that you're pregnant? I know that you love your children. What can we do to help you parent them the way that you want to? What was it like when you lost your child? Are you open to us talking about neonatal abstinence syndrome today? We're using some medical terminology, and people might be like, what is that? And be like, I'm so glad that you asked. Let's get nerdy together. So notice that the past statements were just statements. They're closed. They're very like, okay, what do I even do with this? These are conversation starters. These are fun. Super fun. We also have this super helpful slide to kind of remind us that medication during pregnancy for substance use disorder is effective, it is helpful, people need to know about it, people are afraid to talk about it, and we need to be, because it is life-saving. The benefits of pharmacotherapy, I can never say that word right, and nobody say anything, for OUD during pregnancy outweigh the risks of untreated OUD. We really need to be talking with people about the benefits of medication because a lot of people don't even know it exists. This is a quick little soapbox. I cannot help but do my little soapboxes on top of my soapboxes. It is like a tower. So quick note for everybody, all patients with an OUD diagnosis must have access to medication, right? And then all patients with an OUD diagnosis need to be prescribed naloxone as well, okay? So that's my little soapbox on a soapbox on a soapbox, right? Let's talk about harm reduction. How are we feeling? Feel free to shake your hands around, move around. We're feeling great. All right, awesome. What is harm reduction? What we're talking about in this instance is evidence-based approaches that is critical to engaging with people who use drugs and equipping them with life-saving tools and information to create positive change in their lives and potentially save lives. Harm reduction does not promote or encourage drug use, but helps people make healthier choices for themselves. These are things that I think not enough people are really talking about. And so even though we as providers and overall amazing people, the fact that you even showed up to the Learning Series already makes me know you are my people. And also a lot of times we just assume that our patients are also on that same page. So friendly reminder, we're all coming in at all different stages. So what are some things that providers can do right now? When we think about harm reduction, a lot of times we just think like, oh, get you some syringes over in a van. But there's actually a lot of things that providers can be doing with their patients and clients. So we want to really encourage testing. Hep C testing, syphilis testing, testing, 1, 2, 3. Offer education and resources more than once. A lot of times, people need to be offered these educational resources more than once, and that's great. Know your client rights and myth bust. We're going to have an awesome presentation about DHS stuff. I don't remember if it's today, but it's one of the days. Make sure you're there for it. But making sure your client rights are things that you feel confident in, things that you can also help your clients be confident in. Suggesting opportunities for community, creating a safety plan, and updating it regularly. Just because they did it during an assessment doesn't mean that they can't check in with it pretty regularly. Make multiple copies, put it on their, tell them to put it on their fridge, give it to a trusted person in their community to help them, and regularly updating it. We want to encourage safer use practices, supporting medication, providing prenatal care and nutrition support are also harm reduction strategies. If you already knew about that, great, you're rocking it, you're already doing it. And then advocating for postpartum support. Building trust and fostering non-judgmental communication is also starting that harm reduction pathway. So there's so many different ways that we can kind of start the train. Here are some things that patients can do that we can encourage our patients to do. So keeping a record and keeping track of how much they're using. A lot of times our folks don't know how much they're using. And so even just having that acknowledgement of knowing how much they're using can be super helpful. Setting some limits, switching to a safer method of use, making a safety plan, finding community, being honest with their care team can be a form of harm reduction. And so we are working really hard to foster that because it's really hard to be honest with a provider that we know is going to be coming in with some stigma and judgment. Again, my super high soapbox of naloxone saves lives. I hope that you hear that a million times today and every day. Maybe you get a cool bumper sticker like me, you know? So get some naloxone and share it, talk to people about it, just kind of normalizing naloxone. Lastly, I really want to cover some tools and resources, things that people can do in order to make people feel really confident in their navigating this on their own, okay? So one thing that I know that providers are already using in our region is the SAMHSA clinical guidance. So this can be super useful for just getting information around prenatal care and infant care, maternal postnatal care, all of that. We also have some ASAM recommendations for pregnancy and OUD, which is awesome, also helpful. And again, y'all are going to get these slides, so I love that y'all are writing it down, and also you'll get this. Our National Harm Reduction Coalition Toolkit, this one I do have a QR code for because they made it, and I was like, oh, if you're gonna make me a QR code, of course I'll throw it in there. This one's really helpful around stigma-reducing language, trauma-informed care, client rights. I would be remiss if I also didn't include these, so you'll get these here, the Mother to Baby, Postpartum Support International, and the National Association of Perinatal Social Workers. And then I have a shameless plug for a program that I don't think people know enough about or talk about enough. This is a CareOregon health share program called Care Baby. And what's cool about this is that you get free stuff. And I don't know about you, but I love free stuff. So making sure that your patients and clients are registered as being, I guess, is registered, making sure that their status, their pregnancy status is updated with OHP, super, super important. Because then we know to give them some free stuff. They'll get some pamphlets, and that's cool, but they'll also get a newborn like starter kit, and it has things like, you know, a booklet and a thermometer and some cool sleep stuff. And then they get to choose a big cool prize, which I love. either a 1-month supply of diapers or a car seat or a portable player and bassinet. Cool free stuff. Love free stuff. And so yeah, those are I think that's my last slide. One thing that I do want to encourage today, you'll notice that there are some awesome stickies along the walls where what I'm hoping that we do today is, during lunch or you've got some time, you want to break it up a little bit, answer some of these questions, and so that way we can kind of help each other out. So the questions that are along the wall: what tips do you have in supporting pregnant folks with SUD? What resources do you recommend that other people check out? Where do you get the most support when you have questions regarding SUD and pregnancy? And then what tips do you have in reducing stigma? So if there is something that is calling to you, I have a few markers that are kind of like below the stickies. And what I'd like to do is at the end of the learning series, kind of compiling all of this and creating a resource for all of you. So I think that will be a really helpful way for us to learn from each other. So yeah, that is all I have. And I'm wondering if people have some questions, because I'd love for us to now kind of have a little bit of a dialogue of questions that we can kind of talk to each other about. Because these are kind of our percolating, getting the ball rolling for the rest of our learning series. Oh, hey. Oh my gosh, earlier we were talking about how we love your Daughtry shirt.
Thank you. I went to this concert 2024 Daughtry.
Stop. So cool.
Yeah, thanks, Mom. Love you. So I wanted to ask about...
I thought you were calling me Mom, and I was like...
No, my
Hey,
mom.
girl.
So with motivational interviewing, the ask, listen, tell, I got the information on the ask and the listen. Now, when we get to the tell section, I would like to hear a little bit more about that portion, because the ask and listen, of course, the ask, we ask, and then the listen is more for the client. And it's a game of ping pong is what I'm seeing. So what is that tell section? Can we get a little more of that?
Yes. Things that we really want to make sure that we're highlighting with the tell. We're using medical language. We're not using language that has a bunch of stigma, right? We want to use some backed up information. We're not just using our own personal opinions. One of the tricky things about using medical language is that sometimes it's too medically. So we have to kind of balance both using medical language in a way that is destigmatizing, but not using language that we know won't land with the client. So this is an example of, I know my client is not gonna know what the heck neonatal abstinence syndrome is. I know that. But what I'm hoping is they might say, what the heck is that? And then we can kind of start a dialogue. And so using language that can open up a conversation, that's backed up by data and that we have some research. So something that I like, oh, I'm sorry, y'all might get a little seasick here. There are some suggestions of the beginning of these statements. So we know that blank, blank, blank. We know that medication for opioid use disorder is safe and effective. Starting that off, we're using language that we think that they might be familiar with, but also might open up more of a conversation. Does that kind of help? Feeling good? We're feeling groovy? Okay, cool. Love the tattoos, love the ink. Yeah.
You talked about community and connecting mothers to community resources. Is there, that is great.
Yes.
Is there a listserv or a forum or something that case managers can access? Because there's things for SUD resources and other things.
Yeah.
Where can these mothers go for community?
Yes. Oh my gosh, that's such a good question. I'm kind of hoping that there's someone in the audience that's I know of a community, because you're right, there is not, there is, if there is, we need to definitely know about it. I guess I was thinking of more of just their own community and whatever community that they might already have, as well as, yeah, there definitely needs to be more specific on. Kayla, can you think of anything?
Yeah, Street Roots actually has booklets that can be accessed online, or you can pick them up, a physical copy of them from their office, and they're updated regularly. And the keyword there is updated, because I know we've all had a sheet one time that we've used and the numbers go nowhere. The second resource is the Recovery Network of Oregon has a website, and they have a really great kind of database for all kinds of different needs, community resources. So I would try those two. Anyone else have any that they kind of use on a regular basis?
So it's a little out there, but there are meetings everywhere for literally anything under the sun you can think of addiction-wise. And a lot of people can find meetings. They have apps on almost every phone. There's websites where you can go to find meetings in your area, and people can like meeting hop. And part of this experience is finding community. It may be harder for them to find community specific with pregnant women who are also experiencing substance disorder, but even suggesting that there are multiple meetings, it's tried and true for a reason. There's meetings for a reason, and there are tons of them all over. So using those basic websites or an app where you can find meetings in your area could be a really good resource for them to find a sense of community and not feeling alone in their journey.
Oh, yeah, Kayla's coming.
I'm gonna go there first and come right back to you.
You are the best. I'm sorry, we made eye contact. I'm so sorry. I'm a chronic eye contactor.
So Project Nurture is a great place for pregnant and postpartum people with substance use disorder to connect with others with shared life experience. And there's Project Nurture sites at almost all of the major hospital institutions in Portland, and you will learn a lot more about it over the course of these 3 series.
Yes, I'm so glad we have some Project Nurture representation. Yes, yes.
Thank you. I don't feel like I need a microphone, but let's do it. So I think it depends on what type of community you're looking for, right? So the Project Nurture was my first go-to. I couldn't see who said that, but thank you. So that's really, and then they have peer supports, and they have social workers and the medical staff. Parents Anonymous is the intersection of people with substance use disorder and parenting. There are also some community-based, and then there are, so my nonprofit specifically works on
Where are you at?
Project Patchwork.
Rock on.
So we get a lot of referrals from Project Nurture because what we're trying to do is create that community and for people in recovery housing. And then if you're looking for like physical resources, I think the best thing to do is when you call a number, before you hang up, you say, do you have any other resources? Do you have any other phone numbers? Because that's how I consistently learned. And then they might not have anything for you, but they might have 3 phone numbers. Mm-hmm. So, and I understand the need for case managers to want like listserv and stuff like that, but that is such a heavy lift. And so it's just like, you can take down my phone number and call me, or actually just text me, and then I'll text you back. But it's about asking, do you have any other resources, and then following up.
I love that, yes. And just from like a show of hands, if anybody is part of like a Project Nurture or is part of Project, awesome. That way, like if people have questions, yes, absolutely, please, yes, absolutely. But that way, like if people have questions, want to talk about it more, absolutely, these are your people. Awesome. Awesome. Feeling good? Thank you all so much. This was so fun. I love hanging out with you. And I'm really excited. We have a really nice, good break. So we're going to use that time to connect with people around you, answering some of those questions, and seeing what we've got next. Oh, yes. Did you have a question? Yes, please.
I use Haddon a lot.
Haddon?
Yeah. Which is the homeless Alcohol and Drug Intervention Network, is that what the acronym stands for? But it's awesome.
Thank you.
I have one. I learned about Healthy Birth Initiative. Anybody? It's support specifically for Black mothers in Multnomah County, and it's 100% free. There's no income cap on there. I heard yesterday from somebody who works there that it's like underutilized. So Healthy Birth Initiative. It's support for Black mothers in Multnomah County.
Amazing. Awesome. Laura's my last one here.
So Yasmin's Love does a doula with an intersection of substance use, and it's specifically for African-American moms.
Amazing. Now, you might be percolating of other resources, and that is exactly why I have these questions here, so we can all kind of help each other out. So I definitely encourage that. Cool. Well, thank you all so much. Enjoy your break.